childhood has been well established to be associated with increasingly severe adverse effects by both retrospective and prospective empirical investigations. Clinical descriptions of interventions designed to address the effects of childhood trauma date back many decades as well. However, empirical research examining the efficacy of these treatment methods is a more recent development. When we began our efforts to design and evaluate interventions for this population of children, there were no published scientific studies evaluating the efficacy of interventions designed to specifically address childhood post-traumatic stress disorder, PTSD. In essence, trauma-focused cognitive behavioral therapy, TF-CBT, for children and adolescents was developed and evaluated in response to this clear gap in the scientific literature. Beginning in the mid-1980s, at separate clinical research sites in Pittsburgh and New Jersey, we began conducting independent research studies to identify the specific problems exhibited by children who had experienced trauma, with an initial focus on sexual abuse, in order to inform the development of evidence-based interventions for this population. We initially implemented and examined the clinical benefits of preliminary treatment protocols and conducted several independent randomized controlled trials of trauma-focused individual as well as group therapy models. TF-CBT, as described in Treating Trauma and Traumatic Grief in Children and Adolescents, TF-CBT Web, and this book, reflects the integration of our earlier treatment models as well as our ongoing collaborative efforts. Our initial large-scale multi-site collaboration examined the efficacy of TF-CBT in comparison to child-centered therapy. The results demonstrated that, compared with children and caregivers assigned to child-centered therapy, those assigned to TF-CBT exhibited significantly greater improvements with respect to PTSD, depression, behavior problems, feelings of shame, and dysfunctional abuse-related attributions, while their parents reported significantly greater improvements in abuse-specific distress, depression, parenting skills, and parental support. Additionally, these findings were generally maintained over a one-year follow-up period. The findings of our most recent multi-site dismantling study documented the overall efficacy of TF-CBT for young children in both 8 and 16 session formats, ages 4 to 11, while highlighting the benefits of the 8-session trauma narrative condition in most efficiently and efficaciously helping children overcome abuse-related fear and generalized anxiety. The results also suggested that the skill-building components, and the parenting component in particular, were perhaps most critical in addressing externalizing behavior problems, replicating earlier findings. The efficacy of TF-CBT for children exposed to intimate partner violence, IPV, also has been recently evaluated in a randomized trial conducted in a community setting. The results of this investigation demonstrated that, compared with children assigned to client-centered therapy, usual care, those assigned to 8 sessions of TF-CBT exhibited significantly greater reductions in IPV-related PTSD and anxiety. Recent studies have further documented the benefits of TF-CBT for children who have suffered traumatic grief, children traumatized by the events associated with 9/11, as well as Hurricane Katrina, and child populations with high trauma exposure rates, including children in foster care and children exposed to violence and traumatic loss in low-resource countries. While there are many approaches to treating childhood trauma, recent reviews of the empirical literature suggest that TF-CBT has the most extensive empirical support for its efficacy in treating children suffering from PTSD and related emotional and behavioral difficulties. Thus far, there have been 22 scientific investigations examining the efficacy of TF-CBT, including 12 randomized controlled trials. In addition, TF-CBT has received very positive ratings for efficacy, feasibility, and readiness for dissemination based on extensive treatment outcomes.